I bet it. I bet it.
Here
Anna.
we go. Tuesday training for practitioners. I'm so excited to be here with you guys. I'm in a new backdrop. So this feels like it could be like a Zoom backdrop, but it's not. It's actually real.
Mhm.
But I'm happy to be here with you because that stays the same. Tuesday training on Tuesdays at noon Eastern is one of my favorite hour blocks of the week because we get to come in and talk shop casually, but connected with all practitioners who are both movement and manual practitioners. I'm Gina Schatz. I'm hosting you for the hour, and I am both a manual and movement practitioner, and clinically along the way developed my own method and realized there was certain anatomy that I needed to be able to implement that method. And so I love pouring that anatomy into other practitioners so you can also do great work. I also love teaching my method too. So we do that on a 1-year track that starts middle of the year each year. And it's application, you got to apply to get in and all the good things. And it's also a super intensive, powerful, volume packed year. So it makes it really fun to move along together on that year track. So for those of you who are here live, welcome. Lori, welcome back. I love having you here. I love having you on camera. I love having you in the audience and also in the front line of all of our conversations. You trailblazer, you. Thank you. Len, it's nice to see you. I'm glad that you're here. Well, we don't see you, but I'm glad to see that you are here. Please feel free to come on camera at any time and join us in conversation. And for those of you who are here and not on camera and can't be on camera, you can feel free to come off mute and use your voice to connect and contribute to the conversation. And if that's not possible because of where you're at, maybe you're driving or something, that's okay too. You can use the chat feature. Don't text and drive though. But you can use the text feature and drop your questions in. And if you're watching on the replay, you can also leave your questions here because I'm delighted to answer questions. Now, as I say that, I hear some of my mastery practitioners going, "You don't answer questions." I do answer questions. I do answer questions, but here's the thing. Here's like as if there's only one thing. Here's the thing about the way I answer questions. What I know about solving complex problems for clients with complex pain issues, and I do work on them clinically and I love them. I don't love that they're in pain, but I love solving it. What I know is that there is no anatomy book on the planet or any checklist that exists from any teacher or educator. There is no sort of mindless way to just go through the motions. And I mean that with all love and sincerity and compassion because, hey, Gary, nice to see you. Because when I started as a massage therapist, part of my training was full body massage. And, we had an hour to do that. And then I had some employment where we got to do the same full body, but in 30 minutes. And then that, really makes you laser sharp and get you like really trained to do it quicker and faster. There's some things that we do in my training method where folks are like, I don't have time because you got to practice to make it quicker, right? We all have that. And the point I'm getting to here is that once I figured out whatever I was going to do in that hour or that 30 minutes to create a full body massage, I didn't really have to think about it anymore. I kind of had my rhythm. I knew what I was going to do. I could almost tell how much time had passed just given the part of the body I was on because I had a rhythm and I was doing it over and over and over again, like rote. And I would say for those of you who teach movement, same thing. You teach a movement class, basically how long you've been doing the warm up. You know how much time you have and how many movements you can put in the middle of your class. So the point is, when we're solving complex pain issues, there's no rote memory to it like that. There's no sequence that you go through every time so that you almost can be mindless about it. Mindless not meaning that we're not thinking or smart when we're doing massage or a movement class. I'm still mindful. I had to be very mindful to get the sequence. But once I got the sequence, it was rinse and repeat. It's not like that when you're working with complex pain issues. There's no rinse and repeat. So back to how do I answer questions? I answer questions supporting you all in being mindful about how to get to the answer more than just give you the answer. Because if I give you the rote answer, it'll only work on a certain number of case studies or maybe even only one. And then how have I really supported you? How have you gotten value out of being here if you can only do a one and done, but it doesn't actually rinse and repeat? To me, there's no value there. So usually the folks who show up every week willingly are privy to the game. Hey, Rhonda, nice to see you. And they know that you all know that part of winning this game on solving pain issues is to be able to think through that. And so that is how I answer questions. I make sure that I can tell that you have the information, number one, which is the anatomy that I teach. Do you even have the information to draw from? And yeah, let's do that. And that's a lifelong track. And then are you thinking through that information in a way that I know no matter what shows up for you with your clients and patients and students, that you'll be able to think your way through the answer. So the answers that I offer are twofold: steeped in knowledge and strategically thought through. And if you love that, or you don't know if you love it, but you're into it, great, you're in the right place. I'm so happy to be here with you, by the way. So thank you for all of you who show up every week. I love it. We spoke last week about connective tissue. We did a few, we did kind of, I thought it was a quick run through. We did cartilage, we did ligaments, we did tendons. The week before, we spent our whole time together talking about fascia, because it's a little complex, a little deeper. Truthfully, we could spend probably a week talking about each of them and still learning. So I wouldn't want to misrepresent any of those any of those soft tissues and say, oh, you only need, 15 minutes and you're good. I tend to give you like the greatest hits. Do you guys hear that noise in the background, by the way? No? Okay, good. I'm house sitting for my brother and sister-in-law. This is side, just keeping it real. And they have a Roomba. And I didn't know what it was the first time. I was on the second floor and I'm like, is someone breaking in? Because every house has their own sounds or whatever. And this was really like intrusive. Well, in the few days I've been here, this little Roomba has never followed me into this office space where my computer is until right now at Tuesday training. So he's running around underneath the desk right now and kind of loud. So I just wanted to make sure he wasn't distracting. Okay, good. Back to focus.
It's doing clinical assessment for cleaning.
Yes, exactly. It's got a very methodical way of moving through the lines. Yeah. Apparently, they're like really hard to program. Like you have to like do the square footage of your house and stuff. I don't know. My brother was explaining it to me. But anyway, so here we are. He's doing his own work and we're doing ours. Okay, so back to connective tissue. I wouldn't want to underestimate the value of any of those connective tissues and leave you all thinking that you only needed 10 minutes of it. But I do tend to just train with the greatest hits, kind of like, here's an idea and go run with it. So I'd love to open up our time together today with some opportunity for Q&A. I know you guys all participated in the last few weeks that you were here, and maybe you weren't here and you do have questions on that. So I would love to do this for us today. I'd love to open up some questions on any connective tissue questions that you have, and also open up for any other Q&A that you have. So speaking of strategic thinking, I've already given my preamble to how we're going to think through that. But if there's any questions that you have on any anatomy that you're learning on the knowledge part, I know some of you are inside our academy right now taking some of our anatomy courses. And there's always questions. I got an email today. There was someone that had 4 questions about quizzes, which is fun. I get to roll through those. So if you have any anatomy questions, they don't have to be from inside our training academy. I'm here to help support you with your anatomy learning wherever you're getting that. I'd love to do Q&A on connective tissue, any Q&A you have on anatomy. And then if you have any questions about any client work that you're doing or any functional movement that you notice in some of your students that you noticed something was off, but you're not quite sure what that was, we can roll through that today too. So it's a little bit of it's kind of my theme this week. It's a little bit of a potpourri, potluck, bring what you have and let's sort it out. And they tend to be really rich, by the way. So I'm looking forward to that. So first off, any questions on the connective tissue that yeah, Lori, go ahead. Yes.
I'm like, I have one. I have a question around it, and it is in regards to ligaments. So ligaments. So when somebody says that they have a sprained or a strained or a fill in the blank other than torn ligament, I get that it's gone too far. It's gone way too far as the strain or the sprain. And since they're so like they're meant to stabilize, right? Connecting bone to bone.
Right.
So I'm wondering what and I probably already know this if I would have thought through it a little bit more, kind of the process of getting it back, because getting it back to its fully functioning self.
Yeah, it's a really good question, actually.
And
So
are they
muscle,
feeling it? And then one other quick little thing, are they feeling it though in the ligament, or are they feeling it in the muscles around it? I'm wondering.
they both. And
Both.
I'll explain that. So make sure
Yeah.
I get both parts of this question for you, okay? So
Okay.
first is that when a ligament is strained,
Hmm.
and I'm going to just preface this right now. I know that there's a specific use of the word strain and a specific use of the word sprain in the body, and I sometimes flip them. So I just want to, full disclosure, say that. My
Hmm.
understanding is that a sprain is in a muscle and a strain is in a connective tissue, and I might have that wrong. So I might interchange the words, and I just want to
Okay.
preface this by saying I know a lot, I don't know everything, but I know what I know. So the difference between a ligament being injured in that way or a muscle being injured in that way are really different. My understanding of a muscle, I think it's strain. See, now I flipped it again because I just said sprain on a muscle. See, this is how I do this with these two words. And I don't want to get us confused and miss the point. When a muscle is injured in that way, it's when it is simultaneously being lengthened and needing to contract. And the muscle's like, what the freak? And then there's a response to that. Sometimes it's a response in the muscle spindles. Sometimes it's a response at the connective point of the muscle, which is at the tendon. Okay. And that is a very different quality and call from us as practitioners to resolve than when it's the ligament. That said, and this is starting to answer the second part of your question, that said, I don't know that you can really separate them. So once it's at the point of the ligament where the bones connect, you have to go through the muscle to get to that level of disruption. And we don't have the ability to do a dissection when we're working with live people. So I don't have a way to confirm that for you clinically. But my experience with it is that sometimes it is just the muscle or the tendon, which is where there's a lot of sensation as well. And that's another difference for you if you're trying to figure that out. Now, I realize, Laura, you started by saying ligament, and I'm just giving some qualifiers for us to be able to think through this, because sometimes we have clients who self-diagnose, or sometimes it was diagnosed by, an image, but it doesn't consider the function involved in that. It's just the image that confirms this tissue has been, damaged in this way. So when muscles show up sprained, I think I got that right, there's a lot of sensation there. And when ligaments do, not as much sensation, given the nervous system and the wiring, et cetera. So once it is actually the ligament that's been injured, you still have the muscles involved there because the muscles move the bones, that the connected parts are now injured, right? Okay, so some of the sensation could be similar or different. That's one thing that you want to consider when you're working with someone. Most of it all equals inflammation, whether it's muscle spindles or even tendons or ligaments, for sure. There's some inflammation involved. And so some of you know, depending on the level of inflammation, you don't work on it, right? Like, and some of you know that you do, depending. The work that I would recommend if it was ligament specific is, because we know what the ligaments do, meaning they attach two bones together. If the ligament is in trouble, it's probably because the orientation of those two bones became out of the norm. So that's like obvious when we look at it that way. So then what is the treatment or the remedy or the value add that we can add to supporting that ligament and healing? It's bringing the bones back to where they need to be.
Alignment.
And then alignment, right? It's always alignment, strength, function. That's like a mantra inside our community. So we want to bring the bones back into alignment, which at least takes the strain off the ligament so it can heal. And it's going to be a slower heal when it's ligament than muscle. We said this when we talked about connective tissue because there's not as much blood flow there. And we don't want as much blood flow because we don't want that connective tissue changing with the wind, with every heartbeat, right? We want muscles to change because we want them to change so we can move, so they can contract and lengthen and contract and lengthen and contract and lengthen. But we don't want that with a ligament. So it doesn't have as much blood flow, which means the healing on it is much slower. So first thing is to take the duress off of it by creating the alignment, reestablishing the alignment. And then here's where it gets tricky. And you mentioned this, Lori. If ligaments are meant to stabilize bones, but the remedy for the ligament to heal itself is for the bones to be in alignment, but the thing that does that, that holds that alignment is in duress, what the freak? You hear the catch-22 in that, right? What you get to do then is work the muscles that move that joint and create strength in the muscles that move that joint. But you can't move the muscles to their full capacity until the bones are aligned. We talked about that in our last masterclass, why the lever system is so important and why you would not get the muscle power or the gains in muscle work that you were expecting if there's a misalignment under toe. Okay. So for those of you who are like, misalignment, does that mean I have to have a chiropractor in my office? Not necessarily. Not necessarily. Most of what chiros do is bone and joint alignment for sure. They do that under high velocity, high impact, which is not always needed, especially for folks with hypermobility, which is again a ligament issue. When folks have hypermobility, their joints are less stable without an injury being present, which in some conversations you could say is the injury, because it means that those bones are always going to be slipping and there's always going to be destabilization and misalignment. Okay. In that instance, do I want high velocity and high impact to bring those bones back together? No, quite like you're saying, Gary, right? Like, no, quite the opposite. And so that's one of the things that I love about our method. We do have a way of doing that that's not high velocity and high impact, but it does take some training and skill. I can't teach it to you here in the hour that we have together. Like I said, it's a year-long track, but there are other ways to create that alignment. If you're not the person who does the alignment, but you know that there's something askew with the bones because there's a ligament issue or for some other way that you've confirmed that, just know that that is missing for that person's full restoration. Restoration, that's like a furniture term. Rehabilitation, is that okay, Gary? We're
Recovery,
okay with that?
yeah.
Recovery, thank you, yeah. And so then you want to partner then with a practitioner who does do that. And I've said this before, I'm on a little bit of a soapbox here. Just let me go with it because it's coming in for a reason. Someone here must need to hear it today. If in your mind space, you're like, well, I can't refer my clients out, that's a scarcity model, and stop it. When you refer your clients out to someone who does something you don't do, you're in service to them. They recognize your devotion and they will reciprocate. If you're in scarcity mindset that you can't partner with another practitioner to get the client in front of you the resolve that they deserve, then you're actually not a very generous person of service. And that is my full belief. And I might have pissed people off, and that's okay, because that's just where I stand with it. Figure out what your people need. And you're either going to be the one to provide it, or you're going to partner with someone, not give away to, but partner with someone who can give the resolve that you claim to want for your clients. Okay. And we do a whole series on partnering, because I also don't do acupuncture. I don't do chiropractic. I don't do open heart surgery. I don't do any of that. I don't think I'm less than, and my clients are plentiful. So just be realistic about what they need and who's going to be the one to provide that if you need to have a network of partnership. I also don't do, dental work either. And my clients need all of that too every 6 months. So, doesn't mean they're not going to come back. So there's my total in full answer for you on ligament. Sorry, did I cover it for you? Did I cover both parts of it too?
Yeah, it's interesting. My mirror neurons were like, oh yeah, I remember that. Oh yeah, I do that. Oh, of course, of course.
Okay.
So yes, so thank you.
Yep, great. Sometimes just review is what we need for
Yeah.
confirmation, and that's good too. Awesome. And it was a great question. All right. Any other questions on connective tissue from the last 2 weeks? Gary, you got something?
I had a client who called me up yesterday, and I hadn't seen her in a while. And she said, I'm having some leg pain. I said, is it in both legs? She said, yes. And I said, can you describe it? And I said, does it feel like muscle pain? And she said, no, it kind of feels like, pins and needles. And I said, this sounds more like some kind of nerve compression. And this is a woman who sits for a long time, a long time. And I said, it really sounds like it might be coming out of your L4-5S1, some kind of nerve compression going on there. And she said, well, what should I do? And I've actually done Soaz work with her before because of her long-term sitting. And so my question is, my advice, which was to start stretching your psoas and see if that eliminates the tingling and the pain, was that, just on a phone conversation, the right advice for her.
So your question is, did I give the right advice, or is your question, is that the right advice to give over the phone, or both?
No, did I give her the right advice?
Oh, okay.
Yeah.
So I love this question. What did you think? So you thought the cause of the tingling was nerve compression caused by a psoas issue?
So throwing the alignment out, or some kind of joint action pulling that would compress the nerves running down the legs.
Okay, great. What joint action?
It would be the L4-5S1.
Yeah, and what would they be doing? What did you think they're doing?
They're out of alignment, so the nerves coming out between the facets would be compressed somehow.
Yeah.
And now I'm thinking about it, maybe it was further down, maybe it was, the deep six. I don't know. It was just off the top of my head.
Yeah.
It was a quick conversation. So
yeah, I get it. Okay, so let me answer comprehensively, Gary. Rather than just give you a yes or no. Let me answer comprehensively, because I also don't know. I'm not in the room with her, and I wasn't on the call with her. And so it even gets like, now we're playing telephone, right? But I hear the question. It's valid. Like, I get it. First things first is when folks call us for advice on the phone, that means that they know you have the information. And how wonderful that you've created that as a resource for her, and someone that she trusts, that she thinks about when she's in this kind of situation, and then reaches out to you. So, like, amazing, right? And so we want to always preserve that, and we want to also figure out how we created it, because how we created it is how you do more of it. So if you created that by the work that she had in the office with you, then keep that in mind, because you didn't create that with her by giving her tidbits over the phone, or maybe you're writing newsletters with tidbits in it, and she's getting tidbits from you in writing, so she thought she'd call directly to get a quicker answer. My point is, like, how did you create that trust with her? Because you want to create it and recreate it the same way. Okay, so there's that. One word that you used on the phone that I would love for you to update, for all of us to update, and thank you for bringing it so that we can all learn from it, is, I agree with you that tingling is a nerve sensation. Absolutely, hands down. You got that, nailed it right out of the ballpark. And when we say compression or pinched, or when our clients say compression or pinched, you use the word compression. Now we're circling through diagnosis land. And we want to be really thoughtful about that. A, because we're not even in the room with them, so we don't have the power to diagnose. Most of us don't have the power to diagnose. Even in our license, we have the power to assess, but not diagnose. But mostly, when clients receive a diagnosis from anybody, not just us, it becomes a fixed statement. It becomes a fixed energy where now they're like, oh shit, this is a permanent thing. I'm going to digress for a tiny minute here, and I'm going to come right back to your question. On this diagnosis idea, I have a very, very savvy client, like runs circles around me in what she already knows so that I can answer her. Love her. Her young child, an 11-year-old girl, was recently diagnosed with Lyme's disease. And what we know about that is it's bacterial. So it's a bacteria gone wry. My words, not the doctor's. But the mom kept saying disease, disease, disease. And every time she said it, I saw the daughter kind of like flinch a little bit, just a little bit, because now she's got this fixed energy of this identity, and her brain isn't even formed yet to shake it off, you know? So I kept saying Lyme's bacteria, instead of, I wouldn't go with the diagnosis thing. I'm really adamant about that, whether it's an 11-year-old on a pathology that's out of my scope, or whether it's a 40-year-old grown woman with tingling in her legs. I'm really adamant about this fixed energy around diagnosis. So we want to be thoughtful, especially because we are on the phone with them. We can't see their visual expression. We can't see their energetic response. We don't know if their eyes got wide when we said that, like, oh shit, I have a problem, right? This person I trust just said a word that's a diagnostic word, and then they're off to the races. Like, you want to be really thoughtful about where you leave people. So thank you for bringing that up. It's just a simple switch, but I say nerve involvement, like your nerves are involved. That symptom that your body is telling you is letting us know that there's involvement with your nerves. I don't know to what level, and you don't. None of us does, because we don't have the ability to diagnose at that level. We don't have X-ray vision. And so then they're just, in the same way that you said to her, Gary, does it feel like muscle? And she said no. Then all we do is interpret for the body and say, oh, that doesn't feel like muscle. That feels like nerve. And it becomes just as neutral, whether it's muscle or whether it's nerve or whether it's ligament, like we talked about before with Lori and her question, right? So we want to give them empowerment around what their body's actually feeling, because that is a freaky feeling. If you don't know what the hell is going on, you're like, am I dying? Is this how it all goes down? Did I write my will? You know, and we can really panic. And especially if there's pain involved too, there's wincing that goes with that pain. So we want to keep them in the conversation and in the solution, because they are the only ones that can solve it. If it's movement related and body related, it's up to them, right? Okay, so nerve involvement versus nerve compression is my first thought on that. Now, as far as the align, does this support you already, Gary? Are we?
Yes, it's refined, but the impact is totally different.
Yeah. And we're all about the implication. Yeah, great.
Yeah.
Okay, good.
It supports me also. So thank you, Gary, for bringing this up. Yep.
Great. Excellent. Okay, great. So, so as far as what's causing it, we don't know for sure. And again, we're not in the room, so we want to make sure we don't sound absolute about it. And your instincts are strong. And she called you because she knew you had the answer, and your instincts are strong. So you probably had the answer, Gary. And you did see her ages ago, and you do know that she extends sits. I wouldn't know that if she called me. I don't know her, right? So of course she called the person that knew her body to that extent that could answer this question. Her subconscious was working really well, and so was your instincts. So again, high five to you. If you think it's sitting related, now I'm going to start asking questions to get to your answer. So just preparing. Yeah. So if you think it's sitting related, and you said so, and you called out Soaz, which is awesome, and you knew the vertebra where the nerve root starts, the sciatic nerve, and even if it was piriformis, it would still be sciatic. So it's okay that you started at L3, 4, or 5. What do you think structurally or functionally is happening while she's sitting that would create that response in that nerve? Because sitting itself doesn't do that, but something about her sitting would do it. What do you think that is, Gary? And I will absolutely walk with you through the answer, but I want to give it to you to think about first. And everybody else, I want you to be thinking through too. Don't wait for Gary to give the answer.
Well, I know that ergonomically her workstation is not correct. I mean,
Okay.
she's told me that before.
Okay.
And so I don't know if it's, whether or not it's more upper body, she's raising it up or working with, or her chair's too low. I have no idea about that, but I know there's something wrong in that area. It's not balanced, put that way. I think where I'm weak is on the anatomy piece. So there could be other muscles involved here besides the psoas, certainly. And it's obviously an imbalance. I would say obviously, but I think there's an imbalance between the QLs, the spinalis, and the psoas. And beyond that, I don't know.
Okay. Okay. Well, let's dig there. Why is that obvious to you? What do you think is happening?
Well, it's just these are the antagonistic muscles that work together to create movement. So, and they're locked in, as we're talking about with a 49-minute piece of research. It's pretty amazing.
Yeah.
So I know that's going on with, I think that's going on with her too, because she's the kind of person that just pushes through on everything with.
Okay. Okay. So we got something here to work with. I wish I had Murph in the room with me. He's actually in the trunk of my car. He's probably pissed at me too, but he's in the trunk of my car, so I can't use him, but I'll use my hand and pretend that this is the spine. Okay. I know that's like a lot of visual creativity on your end. Just pretend that this is the spine. So what's the main joint action? And this is for everybody. But I'm pointing it at you, Gary. What's the main joint action that's happening in sitting?
Flexion of the hips.
Yes. And the main guy who does that, you already called him out.
Well, so as probably some abdominis thing. I'm not sure about that.
No, you got it. No, you got it. Yep. The main guy who does hip flexion, the strongest hip flexor in the body is the psoas, for sure. And the guy who helps him is rectus femoris, which is the center quad, runs from the hips to the knee, the only quad that does that. So flexion of the hip on its own does not create nerve involvement. It's a joint action that's available for sure. The main guy that does it is psoas, and you already called him out, which is great. What's happening right above the hips? What's happening joint action wise right above the hips in sitting? What are the joints and what's happening there? You already called them out, by the way. So you're already 80% to the answer. What are the joints above the hips and what are they doing in sitting?
PSIAS. I'm guessing now because I'm not clear.
Okay, so it's above the hips. So the PSIS are the back of the innominate, so that's the hip bone exactly. What's above that?
Joints above the hips would still be in the spinal area now. We're still
Yes.
about that. Yeah.
Yes, exactly. I'm pulling up an image here. I'm going to hope to get us a visual. I'm really sad that Murph's in the car. Okay, so spine, and you said which ones, which joints in the spine are involved?
Well, it could be anywhere from L1 to L5.
Yes, exactly. Okay, can you guys kind of see that image?
Yeah.
Rhonda's like, no, I can't see it. What about, can you see it?
Yeah.
Kind of. You guys see that it's a spine. It's a happy seahorse. Okay. So that's the sacrum at the bottom.
Got a little of it.
You got a little of it? Okay, good. And no, I can't make it. Oh, I can make it a little bigger. See, Murph is invaluable. We need to give him a pay grade.
I can find one if you want to screen share.
Oh, that would be an idea too, Lori. All right, I'm gonna talk and give you screen share while you're looking.
And then
Tell me
when I'll find it. Yeah.
Okay, great. Okay, great. So let me just continue on from here. And then we'll do a bigger screen share when you have it. Thanks for that idea. Okay, so here's the sacrum, right, which is the back of the hips. And the hip flexion would be happening down here where my finger is. You see? Great. And that is a joint action happening down here. But these joint actions up here should not be in action when we're sitting. Their neutral alignment is, yes, exactly. Their neutral alignment looks like that, right? Like there's a curve. That's neutral. That's not action. What is the joint action that typically happens between L1 and L5 though, when we're sitting?
Yeah. But it's flat now.
Yes, exactly. So that takes us to, again, I'm going to use my handy device here. So if this flattens out, that means that the neutrality, which is this concave curve, becomes this, or even opposite. Enjoy my hypermobile fingers. Lori's got a picture for us here. Great. Lori, you might have to use your cursor though. Yeah, you may have to use your cursor. So go to the, L1, L5 on the right. Oh, hey, what's happening? This is very fancy. Normally I would have a slide deck available for you, Gary, but we did potpourri today.
Yeah, my computer's being glitchy. That's why it might be better for you. Oh, see, there it is. It might be better. It might be less intrusive if you just hold up.
Yeah, we don't see it on our end, right? So maybe not. Do you guys see the image from Lori's screen yet? No, it's just black. Okay, that's all right. Thank you for the offer. I appreciate you being creative and supportive here. Okay, let me go back to this visual. Okay, so this is the normal orientation. So this is neutral alignment. Whoops. Neutral alignment of the lumbar curve. Okay, I did it again. Got to touch these, not touch the touch screen. So neutral looks like this. When we're sitting though, the curve usually looks like this. Okay, and again, enjoy the view of my hypermobile finger. So when this curve is reversed, what happens to the psoas and the other muscles that you named, the QL? You're muted, Gary. You're muted. That's all right.
They're overstretched. That would be my guess. And Rhonda's shaking her head. No.
I know. Rhonda, what do you think they're doing?
Yeah, what's happening, Rhonda?
So the Soaz is shortened, and particularly if we're working at a desk or a screen or we're reading, generally our head comes forward. So the weight of our head pulls on our spine and makes the weight bearing of the lower, makes our head heavier on the weight bearing of our lower back and spine. So it's pulling, and you're losing elasticity in the lower lumbar. Does that sound right, Gina?
I got most of that, Rhonda, even with your internet glitching. And I'm so proud of you because I know what anatomy you're working through right now. So yes, that was genius. Well done. So when we're sitting, I'm just going to recap what you said, Rhonda, and add a bit more. When we're sitting, the psoas is in contraction because it's generating the hip flexion.
Yeah.
But when the lumbar curve is reversed from its neutral alignment, and we have our mantra, our formula, alignment, strength, function, now the psoas that is meant to be in contraction is also shortened, but not contracted and it's shortened. It's called on the slack, where the origin and insertion move towards each other. We talked about that last fall when we were talking about different tension types in muscles, and we had a case study that a chap was weight bearing on his weight, like Rhonda's saying, just our head's weight bearing, but he also had a backpack on. We talked about that case study back in December. And in addition, the QL is lengthened. So the psoas is shortened in the front, but not contracted fully. It's contracted at the hip and then shortened at the upper fibers. And the QL is lengthened. When a muscle's held in a lengthened position and held there, when a muscle's in a lengthened position and held there, what type of tension is that, Gary? Do you remember?
Tensile.
Tensile, exactly. And as Rhonda mentioned, now we have forward head posture, which is the weight bearing that holds the psoas in a shortened position and holds the QL in a lengthened position. And the nerve root where the sciatic comes out is no longer in neutral. So the bones are not lined up, which not only affects the ligaments and the muscles on either side of the lever, but it also affects the nerve root when it's spine related, because that's literally, as you mentioned, the joints where the spine comes out. That's the nerve root. So with that information, with the anatomy now to back you up, Gary, and I know this was a quick run through, what do you think now is causing the nerve sensation? And if you don't know, you don't know. It's okay. We'll walk through it.
Well, I mean, it's the misalignment. I
Mhm.
mean, you've already mentioned that.
Mhm.
And the nerve compression that may be happening is an imbalance of those muscles. But I'm not sure what the question is again.
Okay, well, you're answering it already though, so that's awesome. You're right. When a muscle's under tensile stress, it's that rubber band that's being pulled too taut. Tight is still part of the formula. We talked about 4 types of tightness, right? And when a muscle is in contraction, it's definitely tight if it's held there. And if it's shortened and held there, there's a compacting feeling to the muscles in that area, or muscles in that state. And the bones are out of alignment at the same time, which means whatever assured clear distance is needed between those two bones is now impeded. And that's ligaments, it's muscles, and it's nerves, because it's nerve root at the lumbar spine. So do you think that under misalignment and muscle duress, the nerves would be kind of pissed?
Big time.
Yeah, exactly. And then if you add in what we talked about 2 weeks ago in fascia, you mentioned this too, because you're right there, Gary. You have the answer. You gave me all the elements. We just got to put them together. When we add the 49 minutes of bound fascia that we know from science, and she sits for a long time, which is what you said, she's also binding the fascia around those muscles that are in 2 different types of tightness and pulling bones out of alignment. Yeah. So that's the anatomy behind what happened. Did you guys all follow that?
Yeah.
Yeah. Okay. Can we go a little further with it? Are you open to more, Gary?
Sure.
Okay. So that's the anatomy behind what happened. And as soon as we know the anatomy behind what happened, we have the solution. Typically. So what do you think is the solution, Gary?
Well, I would still go to the Soaz first.
Okay.
And see if we can lighten up that contraction.
Okay.
I because the QL is in tensile stress, I don't really know what to do with that.
Okay.
I wouldn't put pressure on that.
Fair enough.
And
anything else?
I think I would start there and then try to reassess and see how she feels, or what does the lower curve look like or feel like after that.
Okay, great. So I'm going to lean in with you a little bit. You ready to be on the hot seat?
Sure.
Okay. So if I lengthen the psoas or actively stretch the psoas, does that automatically create a reestablished lumbar curve when she's sitting?
Well, probably not.
What caused the nerve to be unhappy?
The misalignment of the spine.
So we know we have to get there. If that's the cause, that's the solution.
Right.
So I love your idea. We know the psoas is involved, but we also know it's not going to solve it because you just said what the cause wasn't resolved.
Right.
Did you follow that? Did it connect? Okay, great. So what else would you ask her to include besides stretching the psoas? Now that you know that the lumbar curve is on the hot seat with you.
I don't know.
Okay, fair enough. You could tell her, and again, this is over the phone, so you got to be creative and think on your feet a little bit, and I get that. I would let her know what's causing the problem to the best of my ability, and you would qualify it and say, look, I'm not in the room with you, but it sounds like, right, without the diagnosis part, it sounds like based on your sitting, extended sitting, there's a couple things going on, and we want to make sure we clear all of them. Meaning there's a couple things going on that you probably got away with up until now. But when there's a couple things going on, they all, the basket gets full of dirty laundry. It's just how it goes, right? So it's time to do the laundry. So we know that her lumbar curve needs to be reestablished the way she was designed, or the pain is going to perpetuate.
Right.
We know that her psoas is held in a contracted and shortened position, and her QL is held in a lengthened position, and both of those on their own would cause a problem. And we know that there's fascia involved as well. So those three things, the alignment of her curve, the balance of her lever, and the length of time that she sits. So what would we tell her? I already asked you this. What I would tell her for her lumbar curve is I would say, make sure when you're sitting, I'm not going to tell her not to sit. She sits. She's been sitting since you saw her years ago. I'm not going to tell somebody to not be who they are, but I'm going to let them know the implication of it and how to make it a best choice. So I'm going to say to her, while you're sitting, make sure your low back is not touching the chair while your rib cage is on the chair. So not just sit forward in your seat and still slouch. That doesn't solve it. I haven't fixed the alignment of her lumbar curve. I need her to have her rib cage on the chair, but not her lumbar curve on the chair. I need to have her thoracic curve that curves in that direction to be touching the chair, but not. Yeah, you got it. You clicked. Okay, great. So we're reestablishing the alignment, which we know is number one. Number two is I want you to stretch your psoas every night and in the morning before you go to work. And ideally, Gary, you would have walked her through how to do that so that while she's lengthening her psoas, she's contracting glute max and doing it the right way instead of just pulling on a muscle to lengthen it without establishing the opposite side of the lever system by contracting the hip extension muscles while she's lengthening hip flexor muscles. So ideally, you would walk her through how to establish a balanced lever action. And then I would tell her about the fascia, which is the third thing on our list. We know that she sits for more than 49 minutes. It's bound AF by the end of her day. And I would tell her that you could take away a whole lot of distress from your body by just setting a timer every 45 minutes and standing up for a whole minute and a half without having to like stop working or do all the things. So now I've created alignment in her lumbar curve. I've told her what muscle to target at the beginning and end of her day, and I've made sure she doesn't bind her fascia for more than 49 minutes, which requires 20 or 30 minutes of stretching that hopefully I will have already established in her morning and evening routine, stretching her psoas.
Great.
Did you get it?
Yeah.
Okay, great. And did you see how the anatomy gave you the answer? Awesome.
But I didn't come up with the upper back thing. That was like amazing.
That's all right.
I mean,
So we
it just makes sense. Yeah.
Yeah. Part of training in strategic thinking means you can think creatively on your toes in the moment. So you would have come up with it with more strategic thinking training. I believe that to be true. Right. I hear my mastery practitioners come to me with ideas. They're like, and then I did this, and then I did this. I'm like, wow, how cool is that? Because they were thinking on their toes. They're in that strategic mind space and being in the solution instead of freaked out about what they don't know. So there's value in that. It just takes practice. Just takes practice. You'll get it. Yeah. Awesome job. So you get to call her back and be like, hey, I got more information for you. I've been thinking about you. I walked it through with my peers and I have some more value for you to add. Do you have a minute? She'd be over the moon, Gary. She already trusts you.
Thank
Rhonda,
you.
would you please speak a little about connective tissue adhesions and scar tissue next week? Next week, Rhonda, is that what you want? Yeah, okay, we'll do it. Thanks for giving me a topic. Absolutely. I'll cover that next week for you for sure. And if you have some client case studies that you want to work through specifically, we probably can fit that in too. All right, awesome. So time flies when you're having fun, guys. We have like 4.5 minutes left. Is there anything else on your mind for today? We got our topic for next week, which is great. Did you guys get value from our conversation today on ligaments and tingling? Okay, let's do a round robin. What was your takeaway? Digestion is always great, and I don't always leave time for it, which is, I'm sad about that. So we have a couple minutes now. What's your top takeaway from today? What was your aha? Everybody willing to share, Lori?
Yeah, my aha about Gary's client is that even in that little bit of information that she gave you, we had all the information. We literally did. Like, she sits for a long period of time. She sits for a long period of time was the major takeaway. And then how you went back to the anatomy, the joint action, Gina, the anatomy, and then the muscles, and then how to create a treatment plan for her. And also, what was it about reframing our language around disease and different, and what was it? Not tingling. Yeah, that was lovely as well. Thank you.
Oh, good. Awesome. Rhonda's typing hers in because she's working with her internet today. Thanks, Rhonda. I'll read yours when it comes through. Gary, you want to go next? What was your takeaway? What was your aha moment today?
Well, it was a whole complex. I mean, how this whole the whole thing wove together. I forgot about the contracting the glute max and working on the Soaz. So that was a nice reminder, because I know I've had her doing Soaz stretches, but I can't remember whether or not that was a piece of it. The upper back part of it was just like, and to tell you the truth, I've been trying to get her to get a chair where she can adjust it. But I think the 49 minutes with the fascia thing is so powerful. This is really what happens to you when you do or don't do this.
Exactly.
So I'm always trying to get her to get up at a half hour instead of 49 minutes. But I mean, if she can start thinking about it at 30, maybe she'll get up at 49. I don't know.
I have a feeling she will now. It usually takes something kind of scary and painful for folks to to take action on it. So I wonder, you'll have to let us know, Gary.
Yeah, I will. Thank you.
Yeah, exactly. Especially if, Gary, her tingling gets worse by the end of the day. That's also more information for her. It's the way she's using her body that's creating increased tingling. And one final nuance for you as well. I wouldn't give her 49 minutes to stand up, because whatever she's engrossed in, she'll wait till 52 minutes and now it's too late.
Yeah.
I always give them 45 minutes, even though we know the science is 49, not as a way to keep them out of the information. Sometimes I'll say it's 49, but I want you to set your timer at 45 so you can finish the sentence that you're typing before you hit send. And then the timer ticks over to a new minute, and now we're at 3 hours, right? So I do tell them that, but I say just focus on 45, and get up, right?
Yeah. Right.
Okay, awesome, Gary. Thanks for going. So Rhonda says sprain and strain differences. I don't know if I supported you on that, but I'm glad that was good for you, Rhonda. Also going through Gary's case. Yeah, we got so much juice out of that, Gary. Thank you.
Thank you.
Maybe ask her to make the font on her screen larger. Oh, so she doesn't, that's a good idea, Rhonda. So she doesn't have to lean in as much. Yeah. Because we do need to get our heads back because we're all forward head postured kind of to the max at this point in our evolution as humans. So with our smart devices who are not making us very smart, but I digress. Anyway, we're all very smart after this hour. Thank you for participating and bringing all of your goodness. I appreciate each of you and the work that you do here and the work that you do in the world. Thank you for contributing to our juicy conversation. I look forward to seeing you all again next week. Bye for now.
Thank you again.